All right, so I think it's going to be time to get started. So good evening, everyone. Thank you for joining the second AMV webinar. And before we're going to start, I would like just to give you a few little notifications. So could you please all switch off your microphone to make sure that we are not going to have any parasite sounds. If you don't do that, I have the power to do it, but that will be better if you do it by yourself. Concerning the questions will be for the end of the presentation. And so you will see that you have a little chat box. To open this box, you have to click on the little button on the bottom left of your screen. And so when we'll have finished the presentation, you can just type in this box the questions. I will repeat the question, and then the lecturer will answer to it. This webinar is going to be recorded, so you will have access to the entire webinar if you want to see it again. And so this evening, or actually it's the afternoon in US and it's in Asia the morning, I'm really happy to introduce you Molly Varga, who kindly accepted to give us a very nice webinar this evening. And so her webinar is going to be on gut diseases in rabbits. And so Molly, please, the floor is yours. And thank you again very much for accepting to do this webinar.
Okay, thank you very much, Charlie. And actually, it's an honor to be asked to do this. So I'm very much looking forward to sharing a few thoughts with you guys. So what I want to do today is actually I want to look in detail at the structure and function of the gut and really look at how we deal with it. I think that there are some geographical differences in how we approach this. And I want to kind of look at the pros and cons of each method, if that makes sense. And you know what, I'm coming at this as a practitioner. I see consults all day, every day, and I see a lot of rabbits with a lot of problems with their gut. So the first thing that I want to talk about, and this is something that I'm really, really interested in and also passionate about, is actually gut bacteria and really how vitally important this is to the rabbit. So I want to start with a few definitions. And the first one is, what is the multibiome? So the multibiome is the sum of all of the DNA within the rabbit. So that is the rabbit DNA, the bacteria, the mites, the viruses, the fungi, the yeast, all of that. And that is actually a massively dynamic and ever-changing equation. And we need to kind of keep that in the back of our mind. The microbiome, which realistically is trillions of organisms, is the sum of the organisms that is located within the rabbit gut. And let's just think about that. We think about gut bacteria, but we shouldn't limit it to bacteria. We should be also considering yeast, fungi, and viruses at least, as well as those bacteria perhaps that are difficult to find and difficult to culture. So there is a lot of stuff in there. And it is a massively, massively functional, dynamic, important part of our patients. And actually what we do to manipulate it and to protect it really matters as clinicians. So why is it so important? Why am I so worried about this? Well, I think the first thing to say is obviously, definitely in terms of my patient at that time, the initial thing is actually its capability to digest food and get energy. And that actually is a significant issue. And as soon as we have any kind of problem with the gut motility, then that affects digestion significantly. What about other functions? Is this massively intricate dynamic system just for digestion? And actually the answer is probably not. And we think that the bacteria within the gut confer a significant proportion of immunity to our rabbit patients. So within rabbits, when they are just weaning and the gut is becoming colonized, presentation of microorganisms onto the lymphoid system via the gut actually informs the production of the initial phase of antibody production for that individual animal. So you can actually see that this can be a massively, massively important thing. As humans, actually, we are now beginning to recognize the importance of gut bacteria and the fact that certain, if there's a preponderance of certain bacteria in the human gut, that is associated with obesity. We are starting to recognize the gut-brain axis and to recognize that actually by manipulating bacteria in the gut, we can manipulate things like immunity and mood. So actually, this is a massively intricate system that I think we are nowhere near to fully understanding the importance of as yet. So I think we can't overstate the importance of this to our patients. So the question then becomes, what can we do to influence this positively? And I think there are various things that are relatively easy to consider, particularly if we then consider which external factors can impact the gut bacteria. So we all know how rapidly bacteria and viruses and yeasts can reproduce, very rapidly indeed. And we all know that it's temperature dependent. So absolutely, if the temperature, the core temperature of the rabbit alters, then immediately the likelihood is the profile of the gut bacteria alters fairly rapidly. And that in and of itself affects digestion and digestibility of the food intake. What other things affect it? Well, actually food. So in terms of the rabbit, one of the advantages of having this type of dynamic system is that it can very rapidly respond to alterations in diet. So for example, if a rabbit today eats loads of hawthorn and tomorrow decides actually dandelions are what it wants to eat, then it can deal with that, and it can deal with that fairly rapidly. And we certainly know that in humans, there's only a time lag of perhaps 24 to 36 hours at most when there's a significant dietary shift in terms of our gut bacteria. And the likelihood is that rabbits having such a reliance on their gut bacteria are actually more able to manipulate them in that way. So food, temperature, what about other things? pH, absolutely. If, for example, the pH of the gut changes because motility changes, then absolutely that will also affect the bacteria. So right here, right now, we can certainly see that there are some very easy and obvious things that we can then do to influence the gut bacteria ourselves. We can promote normal core temperature. We can promote normal gut motility. We can certainly choose what we are feeding these animals, whether it be recovery formulas or dietary items, to promote digestive and gut microbiome well-being. So it becomes a very interesting and very useful tool for us as clinicians. So we've talked a little bit about the bacteria and or the microbiome, if you like. What I want to do very briefly is to revisit the structure and function of the rabbit gut, because this is an amazing, amazing organ, really, if you think about what it's attempting to do. And it's really attempting to transform a very nutrient dilute diet into something utilizable. And it uses a similar sort of method perhaps to the horse a little bit, and certainly very similar to things like chinchillas and dagus. So in terms of this gut, the stomach and the small intestine tend to work in a very similar way to other species. So the stomach, there is some chemical digestion, potentially some mechanical digestion. the small intestine will allow absorption of, for example, simple sugars, things like potassium and that type of thing. So very similar to the way that we understand gut working in other species. But where the magic begins to happen is at the ileo-cecocolic junction. And I call this the guardian, really, of cecal entry. And what it is a valve between the small intestine and the junction of the proximal large intestine and the cecum. And it stops retroperistaltic flow back into the small intestine. And that is very, very useful for our rabbits when we're talking about large intestine and also the cecum. So the proximal large intestine, again, we're all very familiar with this in the rabbit. It is formed of several strong fibrous strips of tissue called taenia, and between these are saccules, if you like, called haustra. And what happens in this part of the intestine is that the very fibrous, non-digestible portions of the diet, those bits that promote gut motility, remain in the center of the lumen of the proximal large intestine, while the smaller, much more digestible particles migrate to the periphery into those saccules or haustra. At certain stages of the peristaltic cycle, these haustra act almost like elevators and shift the digestible material back into the cecum. Because the ileocecocolic valve is present, we don't get retroperistalsis and lack of effectiveness so the digester cannot go back into the small intestine. It is correctly directed into the cecum. And the cecum is the site of most of these trillions and trillions of bacteria, fungi, yeast, viruses that the rabbit relies on for the bacterial fermentation. Periodically, under the control of the fusus coli, which is the pacemaker of the guts, the cecum empties, and very rapidly the cecal contents pass through the proximal and distal large intestine and produce cecotrophs. And these cecotrophs are then re-ingested ideally and largely digested from the stomach and through the small intestine. And this is what gives the rabbit its relative efficiency of ability to be able to digest its poor diet. And the fusus coli is something I would like to also highlight, and I call this the pacemaker of the gut. And this is something, certainly a term that Francis Harcourt Brown historically had coined, and I think it's a very good one. And it essentially controls the direction and tone and wavelength, if you like, of the contraction of the gut. And it responds to various endogenous chemical signals. So, for example, things like aldosterone and also physiological prostaglandins. And that, again, will become a little bit important later on. So, all in all, the rabbit gut in its entirety, if we look at its functionality as well as the multibiome, is actually quite a precision piece of kit, and as I say, allows our rabbit patients to be able to digest much better than theoretically they should be. So what happens actually when these guts don't work? And I think we can probably already see that there are some quite significant consequences. One of my colleagues, very well-known vet in the UK, Richard Saunders, coined sort of a definition, if you like, of gut stasis, or a description of it. And he states that it is where normal peristaltic muscular contractions are slowed or in some cases cease, resulting in decreased production of smaller and firmer fecal pellets, and this ultimately stops. So you can see that actually, in terms of our patients, this can have some quite significant consequences. Now, I am absolutely, again, very clear to say that gut stasis is very common. We see it a lot, but it is a symptom, not a diagnosis. Okay, it is never intrinsic gut stasis. There is always a reason. Whether it is eventually relevant is another matter, but there will always be a reason for it. It's also important to remember that gut stasis is potentially fatal. So while certainly historically maybe we might wait 24 hours and just monitor, these days if a rabbit isn't eating, then I tend to try and get that animal seen and examined potentially within 6 to 12 hours, and certainly I wouldn't ideally leave it overnight. Next thing to remember is that gut stasis in and of itself is often intrinsically painful. So while the cause of it may be pain, actually the physicality of having your guts not moving and potentially bloated or what have you can be very, very uncomfortable indeed. And that needs to be remembered and addressed. And finally, if we think about what is happening to this animal, we might have some quite significant changes going on. That means that any animal in gut stasis, unless there is a significant reason not to, should be stabilized before we even think about going anywhere near an anesthetic. So what happens? For whatever reason, these rabbits become anorexic. The gut motility slows, fecal production is reduced, and what we get is a deteriorating cycle of reduced eating, reduced fecal production. We get interstitial fluids actually moving, shifting from the interstitial tissue into the gut lumen. So we get dehydration quite rapidly. And what we also get is actually very unpredictable secretion and reabsorption of electrolytes. So these animals are significantly unstable. And so just, treating gut stasis as a diagnosis in and of itself is almost inevitably not going to end in success. So I want to start with first contact, and I think this is really, really quite important. I do think it's an emergency. I do train my receptionists and my nurses, technicians, whatever terminology you're comfortable with, to recognise this and address it as such. And I want to see these animals quite rapidly. If an owner phones up saying, actually, my rabbit's hunched, not really eating, a bit listless, it's shifting around, I'm not sure if it's past any droppings, then these are all things that make me think, actually, this animal needs to come in and be seen quite quickly. So, actually, what am I going to do? I'm going to actually go through quite a defined consult, and there are answers to questions that I need to pick out from what I ask these owners. And firstly, actually, how long has it really been going on for? And quite often, when you ask these guys very specific questions, they say, well, it hasn't been eaten since this morning. However, for the past week or so, he perhaps hasn't been eating hay very well, or he perhaps hasn't been eating pellets very well. So it's very important to differentiate between what's being offered in terms of diet and check that you're comfortable with that, as well as comparing that to what the owner thinks the rabbit is eating. And particularly if there are two rabbits within the environment, and that is a very common thing in the UK, is that we advocate having at least two rabbits together, then again, it's very important to try and see if the owner has been able to visualize this rabbit eating, or whether perhaps he's assumed the rabbit to be eating, and we don't definitely know that. I also find it's quite useful to ask about recent events. Has there been vaccination? Has there been a trip to a boarding facility? Have there been building works? Have there been, a new addition to the family? Have they got a dog? Have they got a cat? Is there a new baby? All of those things actually can have an impact on our prey species pets. So again, it's worthwhile having those things on your horizon. In the UK, very much at the moment, we also want to check vaccination status. we are having an epidemic right now of RHD2, to the point that actually it is throughout the country. And we can certainly see rabbits becoming rapidly anorexic and dying of this. So again, in terms of any animal I'm bringing into my clinic, I want to know whether it's vaccinated, whether it's exposed, whether I need to keep it in isolation, whether I can be comfortable about it to a degree, what have you. And then finally, I want to know if there are other rabbits affected. And in most cases, unless there is an environmental trigger or a dietary trigger, and again, that's not necessarily consistent, then mostly it will be a single rabbit out of a pair or a group that is affected. As I say, unless there's something a little bit unusual going on. So what do I do? Actually, with all of my rabbit patients now, increasingly, because I'm very conscious of not sort of changing or affecting them as much when I'm trying to examine them, I actually put them on the floor and I let them wander around, and I can see what they're doing. I can see if they're interested, if they're moving around, whether they are shifting, whether they're exhibiting indicative pain behaviours, whether their respiratory rate is appropriate, whether their respiratory depth is appropriate. All of those things are actually really, really useful. And I'll actually check my respiratory rate and time it before I touch that animal. Then I absolutely do the heart rate, pulse rate before perhaps I even move that animal off the floor. Only then do we go ahead and sculpt the guts and palpate or anything else. Certainly I would get a heart rate and a respiratory rate prior to doing anything that may cause that rabbit pain or distress. And then at that point, because I know that if the guts are not moving, these rabbits can become dehydrated quite rapidly, I will assess the hydration status, I'll palpate the abdomen, I'll be looking for dilated viscera, areas of tension and pain, and I will then, at that point, think about checking blood glucose levels and trying to make an initial assessment of whether that animal is an outpatient potentially, or whether we need to keep these guys in hospital. So I think the diagnosis of gut stasis is often relatively straightforward. And the history, you know, reduced or absent appetite, reduced or absent fecal production, evidence of the behaviour, evidence of our physical exam. Can you actually hear gut sounds? And I tend to sort of listen at least 1 minute on each side, if not a little bit longer, recognising that actually gut sounds usually occur every 30 to 40 seconds. And in a rabbit that's a little bit stressed, maybe a little bit painful, it can be less frequent. So I don't want to miss it if they're there. And I also want to ideally assess the quality of the gut sounds. And then, and only then, am I going to palpate and sort of see if I've got any areas of concern within that abdomen. But at the same time, alongside that, I'm focusing on diagnosing this symptom and addressing it, as well as looking ideally for any signs or evidence of the cause of the symptom itself. And that is a key part of trying to treat these animals successfully. So what about triaging the gut stasis case? If you're anything like me and you have a full diary, then I do rely on my nursing staff to perhaps get out there and get these guys looked at before I can physically get into the room. And it's really important because despite what the owners report, these guys can present in a variety of ways, from, you know, recumbent and insignificant pain to hopping around and bright as anything. So again, it's very worthwhile sort of employing triage so that you can see these in the appropriate order. It's very important to be looking for evidence of pain at that point. And in the UK, we use the Grimace scales. We also will look at indicative pain behaviours such as belly pressing, flinching, shifting weights, shifting position, that type of thing. We will certainly hope to get the vital signs down as soon as possible with the minimum of stress to that animal. We will record gut sounds if we can, And again, we're going to come back to taking a blood glucose level. So I want to address taking the blood glucose level because I think it's a very useful thing to do. But what we need to recognise is that as a test on its own, it certainly has its limitations. So Francis Harcourt Brown published a paper with about 700 or 800 rabbits recorded within it that demonstrated that elevated blood glucose levels seem to be linked to gastrointestinal blockage in rabbits. So far so good. That's a useful thing in order to discriminate between simple ileus and gastrointestinal blockage. And actually that's quite a key thing once we start to think about treating these guys. I tend to use a glucometer for this blood glucose evaluation, and I will use it on a cat setting. So in SI units, levels above about 18 millimoles per litre cause me a little bit of concern. And at that point, what that leads me to do is to actively rule in or rule out a blockage, as well as go on with active stabilisation of that patient. However, the limitation of the blood glucose is that not all blocked rabbits will show a high blood glucose. So rabbits that may have been blocked for a little while will quite commonly have eventually quite a low blood glucose. And some rabbits have a high blood glucose and stabilise fine with no evidence of blockage at all. So again, it is not very sensitive or specific for diagnosing a gap obstruction as a test on its own, but it does lead me to look very carefully for an obstruction if the blood glucose is very elevated. So before we get to further diagnostics, actually, what am I going to do? And as I said, all of these animals receive stabilisation alongside diagnostics, what have you. And my first key thing is fluid therapy. And I assume that all of these anorectic rabbits are at least 5, if not 8% dehydrated. All of these animals, all of them will get analgesia. And remember that during your physical examination, you may have identified other areas of pain, for example, a fracture, or sore hocks, or dental disease, or something else that is external to the viscera of the gut itself. So all types of pain need to be addressed. And that comes back to actually also volume expanding, because what you don't want to do, for example, is give a non-steroidal to a volume depleted animal. So we need to do these things in parallel. And certainly we do give non-steroidals to rabbits that have got stasis where there is a specific indication for non-steroidal drug therapy. I also will give opiates, and we'll talk about those later on. We gather the baseline parameters, so that might be additional things like repeated core temperature, it might be repeated blood glucose, it may well be repeated heart rate and respiratory rate. It may be a Grimace scale pain score, okay? And we reduce the stress of these guys. We keep them with their bonded companions if there is one, and we try and keep them away from predatory species in an area where it's quiet, but open enough that I can still monitor them properly. And then we consider whether we require emergency imaging or physical intervention. So I mentioned fluids, and again, it's very important to remember that there are very, very many ways to administer fluids, but realistically, genuinely, and I know it's unhelpful, but I always say this, is actually the important thing is to give it something wet. Get this animal volume expanded, get it rehydrated. So the maintenance fluid requirements, approximately 75 to 100 mils per kilo per day. Don't forget to add in your insensible losses and ongoing, calculate the deficit as well as the ongoing losses. We can give these fluids via various different access routes, and the fluid rates are actually fairly similar to most of our other patients. So I tend to go with 2 to 4 mils per kilo per hour, or 100 mils per kilo per 24 hours as a very good baseline. But you can give 25 mils per kilo every 2 hours if you need to, if the animal is that unstable, if it requires it. And at this point, ideally, I'm going to bring you back to the fact that quite often these guys have electrolyte abnormalities. So, for example, we may be very interested in the potassium status, chloride status, the acid-base status of these animals. So if we can, let's choose our fluids off of the back of some blood results, if that's a possibility. So, as I said, dehydration, 5%, mild hypermotility. When we're getting towards 8%, we've got dry mucous membranes, we've got a skin tent. As soon as we're getting 10, 12%, then we've got more central changes. So we've got a slow capillary refill time, we've got a fast weak pulse, and we've got a rabbit that is mentally depressed. So what are we going to do? How are we going to get these animals rehydrated? If the gut works, use it. So remember that with your support feeding, and we'll come to that, part of your fluid deficit will be corrected by putting fluid-containing food into the gut. We need to remember that it is important to feed and hydrate the gut as well as the rest of the animal. Quite often for animals that are not too bad and not too unwell, then I will use subcutaneous fluids. And I use those because in rabbits, we know that there is a subcutaneous fracture plane. It means that the fluids disperse very rapidly, and actually there's quite a good blood flow to these areas, as long as that rabbit is not really significantly hemodynamically compromised. What I also do is I add hyaluronidase to my subcutaneous fluids. Hyaluronic acid is the cell-to-cell adhesive in the tissues under the skin. Adding hyaluronidase allows my fluid to spread down really fast. So it's a top tip, it really works, and it allows me to give a greater amount at each area without causing pain or discomfort or damage, and it allows very rapid uptake of fluid from the subcutaneous space. I also, in very small animals or very collapsed animals, will absolutely use intraosseous catheterization as quite an early on form of getting fluids in. You can put anything into the medullary cavity of a bone that you can put into a vein. Initial placement will hurt, so you'll need to use some local anesthetic. The initial fluid where you're moving bone marrow out of the way will hurt a little bit, but after that, it can be a life-saving access route, particularly for your smaller patients. I generally confirm placement with x-rays, and obviously you would want to avoid it if the bone was fractured. But external to that, it's a brilliant way of getting fluids into these animals. I don't like intraperitoneal fluids, and therefore, certainly in rabbits where I feel we've got so many other options, I don't use them. Quite often, you can cause peritonitis, you can puncture dilated and damaged viscera. Certainly, a large volume of fluid into the abdominal cavity, remember that that will impact on that rabbit's ability to move its diaphragm. And rabbits are diaphragmatic breathers. They don't tend to have a great input from their intercostal muscles into breathing. So as soon as you impact how much the diaphragm moves, you impact its breathing. And these animals are already compromised. So my preferred option is intravenous fluids. I tend to use the marginal ear vein, but not always. I certainly will use the cephalic vein or potentially the lateral saphenous, although that can be challenging to fix that one in. I tend to go with repeated slow IV boluses, simply because unless the rabbit is very, very collapsed, or you have somebody that is near it and monitoring it very closely, they tend to wrap themselves up in IV lines, they chew them, they hang themselves, and it all becomes quite stressful. So again, slow IV boluses of warmed fluids at regular intervals. And to just reiterate, if we need to, 25 milligrams per kilogram per hour for the first couple of hours can be life-saving. What else are we going to do? We've got this animal and we've got maybe a high blood glucose. We've started stabilization. We're happy that simple, handling isn't going to tip it over the edge. We certainly then need to consider the value of other diagnostics. And as I said, once I have a rabbit with ileus or gut stasis and I don't know if there's a blockage, then I am going to actively look for one and try and rule that in or rule that out fairly rapidly. Typically, my go-to with this is very simple, conscious abdominal radiography. And we find that that can be very successful. And I can either say, right, I'm really concerned. I'm concerned enough that actually my concern outweighs the risks of sedation, perhaps, and we're going to go and do some better imaging. I also like fast scanning. In terms of that, it's just a really, really rapid assessment of whether I've got free abdominal fluid, whether I've got any motility happening. The skill level with ultrasound is not sufficient to do a very, very good survey. However, I can certainly have a look and to a fairly broad degree say, okay, I'm happy or I'm not happy. And if I'm not happy, then go further. And in terms of that, a lot of the time people say, oh, well, it's hard to scan rabbits, there's too much gas. Actually, what I tend to do is I'll scan them from underneath. So I'm very lucky I've got a cardiology scanning table. I can sit a rabbit on it and I can scan the abdomen from the ventral aspect. However, if you haven't got a cardiology table, it can be as simple as sitting your rabbit on a cardboard box and cutting a hole in it so that you can scan it effectively ventrally. My colleagues in Europe are increasingly advocating the use of contrast in these guys fairly early on. And this is certainly something my colleagues and I in the UK are starting to do. And again, that can be really, really useful to discern where and how rapidly the guts are moving and if, why they're not and whether there's something that is impacting them within the lumen or affecting the passage of the digester some other way. And certainly using barium and, for example, things like Omnipeg. So again, that can be useful. I'm very lucky I have direct access to CT and MRI. So if I need to, we can jump in and we can get these animals through a CT or an MRI. But quite often, the advantage of that is it diagnoses everything else rather than directly diagnosing the gut stasis. And finally, if we get to the point where we're like, you know what, we are certain there's an obstruction, then increasingly I am more inclined to go for exploratory surgery fairly early rather than leave it as long as I can mitigate the issues that I've evaluated in terms of things like fluid balance and electrolyte status. Other things that may be useful, although not necessarily immediately, are just general hematology and biochemistry, perhaps looking at things like urine samples, fecal samples, and what have you. But they are of less direct benefit to diagnosing the gut stasis immediately. So what are the things that can cause gut stasis? Well, largely almost anything. So pain from any cause at all. And on the right hand side of this slide, you'll see pictures of Grimace scales images so that we can try and literally physically pain score. Many rabbits, stress can cause gut stasis. So anything that triggers a sympathetic nervous system response can result in gut stasis. Organic disease, so renal failure, hepatitis, middle ear disease, anything that's going wrong can have a sequel in gut stasis. It may be simply a side effect of previous abdominal surgery. For example, ovariohysterectomy would be a common example of something that may cause post-surgical adhesions. And these post-surgical adhesions can certainly affect gut motility and can cause discomfort as well as dysfunction. And then other things may be directly gut-related diseases, such as things like lymphoma, maybe mucoid enteropathy, things like that. So it's really worthwhile accounting for everything that you can in your initial examination. So I want to go through various iterations again of gut motility dysfunction. And the biggest, most obvious and biggest concern is the gastrointestinal obstruction. Now, we've mentioned actually how to kind of try and rule this in and draw this out, but what are the sequelae to this? So very common to other species, the severity of the clinical signs tends to be dependent on the level of the obstruction. The higher the obstruction, the more rapidly noticeable and the more severe the clinical signs tend to be. And in most cases, an obstructed gut will require surgical intervention. Now, in my hands, if I am not forced to go to emergency surgery, then I stabilise these patients as much as I can beforehand. If we think about our knowledge with horses, horses with colic are twice as likely to die as normal horses being anaesthetised. And actually, I think rabbits should fit into that same category because we don't know the electrolyte status or we haven't mitigated it. So things like that actually become very important. As soon as we have an animal that is in gut stasis, we know that there's a little bit of sympathetic nervous system tone going on there. So we've got an elevated heart rate in all likelihood. We've got an elevated blood pressure. All of these things impact on what we're going to do. So I try and stabilise these animals as much as possible. If I am going into these animals surgically, then again, I think it's always worthwhile highlighting that we need to use very good surgical technique because what we don't want to do is to cause post-operative problems. So again, direct handling needs to be minimised. I try and only handle viscera with instruments if I can. And if I can't avoid using my hands or swabs, then those are moistened. So I use non-powdered gloves. All of them are moistened with sterile saline. I only use moistened swabs and I try and minimise the area of gut that I touch. And I try and get very good hemostasis so that we don't have blood clots sort of sitting in the abdomen after closure. And we're going to talk about pro-kinetics in a minute, but to just reiterate that pro-kinetics are contraindicated post-surgery as well as in the case of an obstruction. And this is why it is absolutely vital to understand what you're dealing with. So dysbiosis. This is a very common consequence of gut stasis, and this is a challenge to or an alteration to the gut bacteria. We can also use it by inappropriate use of antibiotics or something like that. But we've talked about the multiple functions of the microbiome. As soon as that's messed up, then actually these rabbits are in a significantly more precarious position, perhaps than we might realise. So with these animals, you will get a change in fecal consistency. You'll get an alteration of appetite. What we may be on the lookout for is evidence of production of bacterial endotoxins. For example, firmicutes are one of the most common bacteria within the rabbit gut. One of the families of firmicutes are Clostridia. So if we have a lot of Clostridia that can produce bacterial endotoxins, then if these are selected for by antibiotic use, by changing gut motility, by changing temperature, then that animal may well become toxic. And that's a significant issue for that patient's survival. in these cases, we may look at using adsorbents. So typically, we think about things like activated charcoal or something like cholestyramine resin, and those are given orally to try and reduce the amount of bacterial endotoxin in the gut lumen. But remember, you need aggressive treatment of the underlying cause at this point as well. You have to, there we go. Just having a little bit of an issue getting the next slide to advance. It's thinking about it. I'm sorry about this. Charlie, I don't know if there's anything that you can do to...
I'm going to try to do it myself. I'm not sure. Yeah, up. I was able to switch it. So if you have any other problem, just let me know, and I will change your slides for you.
Okay. What I can't do is I can't see the next one actually.
Ah, okay.
Sorry.
Because we actually can what's wrong with that? Can you see it now?
No, I've got a blue sort of.
Right. So maybe we can try to upload it again. I'm going to remove the slide, and then we're going to try to see if we can. Let me see if I can switch off. No, I cannot exit this mode. So maybe what you can do is just re-upload your presentation.
Okay.
Actually, I can't switch the slides. I'm not sure if people online can see them or not, but if you cannot see your own slides, that's going to be problematic.
Yes, it is. Do you want to try going back to the original screen sharing? Or...
Yes, you can try to do that if it's working for you. Sure.
Okay, let's...
Sorry for this technical issue.
Okay, let's just see if that's... hold on. Okay.
Right now, I just see your slide on dysbiosis.
Okay. Right, so I've got onto my screen sharing. Can you see that or no?
No, I can see your slide on dysbiosis. That's it.
Okay.
The one which was not working.
Okay. Right. I'm gonna upload it again. Okay.
Okay.
So hopefully, apologies
right now,
for
okay.
this.
Right now, I can see. Okay. I can see your. Let's try to do that. Okay. It's.
Okay. Can you see that?
No. Okay. Let me check.
Okay, so the next one is bloat, is that right?
Yeah, but right now I can't see anything. No, I still have dysbiosis right now. Do you see it or not?
Okay. I've re-uploaded it and I can now move the slides.
All right. Well, actually, we are not seeing. Everyone is not seeing the same thing because I see your old presentation and not the new one. Otherwise, I will just change the slide. You know, change your.
Okay.
Oh, here we go. Something is happening. I
Okay.
think that's going to be your new, fortunately, your new slide. No, it's still dysbiosis.
Okay. Right. Well, do you want to change the slides? And I will try and look at this.
Yeah, we can do that. Just let me know when
Yeah.
you change the slide. So
Okay.
I'm on bloat now.
Okay. So bloat.
Okay.
So I'm good with that. Let's go.
Yeah.
Let's see how this works. So bloat. I think we see this very commonly, and this is one of the most concerning things that I think I see in terms of issues with gut motility. And this is where we have bowel loops filled with gas. It is massively, massively painful. And it can be due to bacterial gas production. It can be due to microbiome changes, diet changes. However, it can also be due to aerophagia, for example, if there's significant lung disease or if there's pain elsewhere. As soon as we start getting a large amount of air within the stomach, for example, then actually as soon as that bloats out, we can get a functional obstruction of the pyloric outflow. And what that means is because of the size of the stomach and the air within it, actually the pylorus and the fundus fold over onto each other, and the air and the fluid and what have you remain in the stomach. And actually that is a true functional obstruction rather than a physical one. We don't tend to get torsion in rabbits, but we certainly will see and recognise gastric dilatation. And remember the comments about the diaphragm. As soon as those stomachs get very big, it affects the rabbit's ability to breathe. And it actually also can affect the venous return to the heart if the stomach is very big. Even though there's no true obstruction, in some of these cases, actually, we do need to go ahead and do surgery and get that stomach open and moving again. And it may just be as simple as unfolding that pyloric outflow. Okay, Charlie, can you go to the next slide? So fecal impaction.
Yeah, good.
Yeah, one of my least favourite things. And again, this is a derangement of the motility where the cecum fills but fails to empty. And these rabbits are often relatively happy. They continue to produce their hard feces, and quite often they don't lose weight, or apparently they seem to gain weight, but they are not passing cecotrophs. And what we see with these animals is that the cecum gets progressively more and more full. It's uncomfortable. It eventually does begin to hurt. And these rabbits lose weight. They lose body condition, but they won't necessarily lose weight if you're only assessing them by body weight. They will lose condition, but perhaps the weight will retain or gain simply because the cecum is full of food. They are not eating cecotrophs because they're not producing any. So therefore, what they're essentially doing is starving themselves with a full cecum. And a lot of the nutrients that they're trying to take in are sequestered in that cecum that doesn't empty. I have never really found a successful treatment for this. Use of prostaglandin F2 alpha has been suggested, and I've never had this work. I've had one successful case where we physically emptied the cecum, analgesed it, what have you, and that animal did well for a certain amount of time and then was lost to follow-up. So I couldn't say that surgical approach would be any better than the attempts at medical approach. And my concern is that we don't necessarily know what the cause is. Okay, Charlie, next slide, please. So diarrhea, again, a derangement in the motility. And again, this is a really true emergency. What we tend to find is that unlike other species, we're not certain with rabbits whether diarrhea is hypermotility or hypomotility, and potentially can be either. And again, it means that actually we have very rapid fluid loss, and again, we have significant electrolyte derangements occurring quite quickly. While this can be due to infectious agents such as coccidia, Tisser's disease, for example, or potentially even things like salmonella, it isn't always. And again, it is worthwhile clarifying diagnostically what you have going on. Just a side note that quite often a failure to eat cecotrophs for any reason is often misdiagnosed as diarrhea. Now, rabbits that are not eating their cecotrophs will always be producing normal hard droppings at the same time, and they will generally be quite well. So again, just a point that is worthwhile noting. Next slide, please. So what are we going to use to treat these? And again, I think we need to consider the differences in how we approach these sort of internationally. So certainly my North American colleagues are very much for stabilization, treating the underlying cause, providing fluids, providing analgesia. Yet in the UK, and increasingly, I believe, over towards Australia, we are more likely to use pro-kinetics. Certainly in the UK, this is a cornerstone of our treatment. But who's to say who is right and who is wrong? And I think it's very important to say that actually with pro-kinetics, we should not use these in place of coming to a diagnosis. So what do these drugs do? Well, they promote stomach emptying, or they promote peristalsis along the length of the gut. However, I totally agree that we need to diagnose and treat the underlying cause. And perhaps we don't need to use these drugs. And perhaps these drugs actually can be contraindicated in some cases, particularly if there's an obstruction or particularly post-surgically. So let's have a look at these drugs in a bit more detail. Next slide, please. So firstly, metoclopramide. This is the most commonly used pro-kinetic in the UK. It's one of the World Health Organization medicines of most importance with least side effects. It's a dopamine antagonist and a serotonin receptor antagonist, but it's an agonist at the 5-HT4 serotonin receptors. It can also cause prolactin release, and in general, its prokinetic effect relies on dopamine antagonism and 5-HT4 agonism. It will sensitize both gastric and colonic longitudinal muscle to acetylcholine. So the chemical neurotransmitter that essentially causes muscle contraction. What it actually does, while it certainly works on the colonic longitudinal muscle, it speeds gastric emptying, relaxes the pyloric sphincter and contracts the cardiac sphincter. And we need to remember that the way that we give this is relatively important. There is a high first pass effect, so it is not as effective if it's given orally, and it only lasts a short amount of time if it's given parenterally. So in terms of this medication, you know, we tend to give it 3 or 4 times a day. Perhaps it should be given more regularly to keep the guts mobile. But as soon as we start thinking of giving any animal medication every 4 hours, that is pretty intensive for that animal. And particularly where these drugs are not free of side effects. So metoclopramide can certainly cause restlessness, it can cause alterations to the blood pressure, and it can also cause things like tremors, sort of dyskinesias and movement disorders. Another thing to remember is that as soon as we give metoclopramide with other drugs, the rapid emptying of the stomach affects the time that these other drugs have to be taken up from the stomach. And that particularly is true with things like ranitidine. Could we have the next slide, please? So ranitidine is perhaps my go-to prokinetic. It's a H2 histamine receptor blocker, and this drug shows gentle prokinetic effects throughout the gut. The colonic smooth muscle is potentially probably a little bit more sensitive to the effects of the drug, but it's not necessarily massively obvious. However, again, actually this drug has side effects, and it can have quite significant cardiovascular side effects. So bradycardia or tachycardia, atrioventricular block. It is also potentially hepatotoxic, and we can have sort of allergic type reactions to it. So while it's very useful, it is not without its own issues. Used with metoclopramide, it will potentiate the effect of metoclopramide on intestinal motility. And looking for the evidence base on this, right at the moment, with a recent knowledge synthesis that was done by the Royal College of Veterinary Surgeons, we have no good evidence to suggest that ranitidine is any better than metoclopramide for the treatment of gut stasis, other than anecdote or personal preference. We have the next slide, please, Charlie. So cisapride, this is something we quite commonly use in the UK. I believe that it has been taken off the market in the US, and it's variably available elsewhere. Now, cisapride, again, is a selective serotonin 5-HT4 agonist, and it has a direct effect on the parasympathetic nervous system. Again, it has significant cardiovascular side effects, and this is the reason it was actually taken off the market in the first place, because we're certainly recognising cardiac issues in our veterinary patients, and they were certainly recognising cardiac issues in paediatric patients. In low concentrations, cisapride will actually potentiate ranitidine and the responses to ranitidine, and in high doses it will actually antagonise it. So again, how we use these drugs and in what combination can be quite significant. Could we have the next slide, please, Charlie? And finally, domperidone. This again is a dopamine receptor antagonist, so you're getting a theme, really: dopamine, serotonin, potentially histamine receptors. The gastro-pro-kinetic, and it encourages stomach emptying. And again, it can affect the uptake of ranitidine if it's given at the same time. Yet again, another theme, we've got some quite potentially serious cardiac side effects. It can prolong the QT interval and potentiate ventricular arrhythmias. Also, this medication is an oral medication. However, we have significant first-pass metabolism with this drug. So actually giving it orally means we need to give a higher dose, which could potentially be associated with more side effects. In humans, they don't let people take this for very long at all, and generally the maximum course is a week. We don't know in veterinary medicine, we certainly don't know about that. And actually there is no direct evidence to support its use, even though doses have been published. So again, the support for its use is simply anecdotal. We have the next slide, please, Charlie. So actually, really, what do we need to do? We need to get to the nitty-gritty of analgesia. So opioids, if they're indicated. If there is moderate to severe pain, I don't hesitate. And we know that we're concerned about opioids and the effect on gut motility. A very recent paper actually produced via Alfor, I believe, has shown that a single dose of buprenorphine doesn't negatively affect gut motility. And we also know that in all likelihood, we need to give opioids for about 48 hours prior to the gut motility being significantly affected. So if we need them, let's use them. Now, earlier I mentioned non-steroidals, and the ones that we have today are relatively safe and are associated with far fewer gastrointestinal side effects. COX inhibitors, particularly COX-2 inhibitors, block non-physiological prostaglandins. So we are unlikely to get a negative side effect on the fusus coli with these drugs. However, we may well find that we are starting to get some gut ulceration if we use them at high doses. We know that meloxicam inhibits the COX-2 pathway at fairly low concentrations. So perhaps using this at a low dose in these patients, as long as they're not volume depleted, is sensible. What about other things? Let's think outside the box. Intravenous lidocaine is a really good visceral analgesic for your hospital patients, should they need it post-surgically, for example. And in these cases, again, we've got a study that suggests that IV lidocaine has less of a negative effect on gut motility even than buprenorphine. In my practice, we are increasingly starting to use paracetamol, acetaminophen. And again, we get some mild to moderate analgesia with that. We can use it orally, we've got a liquid formulation, we can use it intravenously. And a wide range of doses have been published, but we're actually getting good clinical effects with very low doses. What about drugs like meropitant? Again, increasingly, we have very little evidence for this other than anecdotal. However, this neurokinin 1 receptor antagonist is an anti-inflammatory, and it is good at alleviating visceral pain. So again, I'm very inclined to use this in gut stasis cases for the pain of the gut stasis, as well as, whether, any other pain elsewhere. Can we have the next slide, please, Charlie? So what else are we going to do with these animals? Well, we are going to support feed them, unless there's a specific contraindication, such as blockage, for example, then these guys need to be support fed. And we need to remember that this needs to happen until voluntary eating returns. We also need to remember that we need to maintain the gut function, and we need to maintain the gut motility. And actually, distension of the gut promotes motility. We also need to be very clear that we are feeding the rabbit, we're feeding the cells of the gut, we need to make certain it's well nutrified and well hydrated, and we are also feeding the microbiota, providing short chain fatty acids to feed those good bacteria within the gut to promote digestibility. There are a lot of commercial products available. You can use crushed pellets that are moistened if you need to. And to remember that potentially we can cause things like food aversion in these animals. So again, to just be aware of that. Next slide, please. So, actually, can you do the next 2 or 3 so that we've got all the pictures? There are various methods of support feeding, and abundance feeding so that they have a lot of things that they like, bugging the hell out of them. So actually, quite often, if you wipe a rabbit's face with a leafy green of something, it might ignore it the first 2 or 3 times, and then it'll turn around and bite at it. And quite often, as soon as it bites at it, it thinks, oh, actually, I quite like that. So while it can be a little bit stressful, and I wouldn't advocate this for a very long period of time, to get them started, that can be useful. But realistically, what we're going to be talking about is syringe feeding a liquid food until these animals are eating voluntarily. And I tend to find that assist feeding doesn't stop them eating voluntarily when they're ready. Next slide, please. What about pre and probiotics? So having said that gut bacteria, the microbiota is essential, let's see what we can do to manipulate it. Prebiotics are dietary constituents that you will use to feed those good bacteria. And they're found in a lot of the normal diets, so things like lignin, for example, or types of cellulose. And these are vital in the production of short-chain fatty acids that feed the gut and its bacteria. So it feeds the cells of the gut lining, and it feeds the bacteria, it feeds the microbiome. Probiotics are encapsulated forms of good bacteria that can be given orally, and we do have evidence to show that certainly in some formulations these certainly can get past the low pH of the stomach and can therefore impact and change the profile of bacteria that we find in cecotrophs and droppings. There's also evidence that suggests that that's wrong. At worst, they're not going to do any harm, and they are very well may do some good. Next slide, please. So finally, we need to monitor the progress. So whether this animal is eating, whether its behaviour is improving, body condition score versus weight, very important, and looking at the hydration and the electrolytes. And again, looking at the type of feces that are being produced. Next slide, please, Charlie. And then looking at this animal's journey from complete dependence to independence. And this is what we call, or look at, certainly in terms of what we call nursing care assessments. And these are a vital part of the feedback on my patients. And what we need to look at with these animals is actually, can they maintain their hydration status without support? The reason. Are they able to maintain their gut motility without support? So without all of these pro-kinetics, whether we've chosen to give them or whether it isn't part of our armory, and whether these animals are able to move around comfortably. And actually getting these guys moving is a significant factor in getting the body wall, massaging the gut and promoting mobility. And again, a lot of this rests on nurses looking at pain scoring, looking at vitals, looking for indicative pain behaviours, and really reassessing our patients very thoroughly and very regularly. Next slide, please, Charlie. And then finally, getting these guys home. I like these guys to be fairly independent before they go home, but it will depend on the individual rabbit and certainly the individual owner. Quite often, they will go home still requiring some form of medical support, some form of supportive feeding. And we need to make certain that the owners are aware of the type of droppings that are being produced, that they understand what those mean, and that they know how to get back in touch with us if things are not going properly. Next slide, Charlie, please. And then finally, prevention. Getting these guys on a really good, healthy diet, addressing their underlying problems, monitoring them, recognising that some of them may need ongoing management, particularly things like, for example, osteoarthritis or chronic renal failure. So making certain that we've looked at the whole rabbit, not just the gut stasis. And then getting these rabbits out and about, give them some space, get them moving, because inevitably the more active a rabbit is, the better its guts are going to move, simply because its abdominal wall is stimulating that motility. Next slide, please, Charlie. So finally, gut stasis is a symptom and not a diagnosis. Act promptly and evaluate regularly, and give them, really analgesize the hell out of these animals. Make certain that they are comfortable. Remember the fluid and electrolyte balance, the acid-base issues that you may well see. Look for them, recognise them, address them. And always, always, always look for the underlying cause. It may not be relevant currently, but it will be there, and we need to understand the issues for this animal. Next slide, please, Charlie. So I've provided a list of references in terms of a lot of what I've spoken about tonight. I hope that you know, these are things that you can have a look at and gain some benefit from. I've enjoyed looking at them. Charlie, next slide, please. So thank you for listening. I'm sorry about the technical hitches. Charlie, do we have time for some questions?
Well, it's up to you. If you have time, we can have some questions. So
I'm good if
right.
It's okay with everybody.
So we have some people congratulate you because that was a great webinar. So thank you again very much, Molly. That was really, really interesting, and I think everyone learned a lot of things tonight. So if there are any questions, could you please just type them in the chat box, and I will repeat them, and so Molly could answer to them. So I guess we are going to wait a little bit for people to type their questions.
Okay, no worries.
There are some thank you. Again, some thank you. Okay, first question. What are your thoughts? Oops, let me see. Oops, this one just moved. What are your thoughts about the use of simeticone?
I do like simethicone. If we have rabbits that have a lot of gas, I use that quite regularly, just to disperse the gas into smaller and more manageable, bubbles. And I tend to find it's quite useful. I use it in guinea pigs a lot as well. I've had one report of a rabbit sort of having a little bit too much and becoming uncomfortable from it, but in general, I think it's safe and I think it's useful.
Okay, and then the second question is what about trimebutene?
That is something I haven't used. It's certainly not something that I've got in the UK. Are you talking trimethoprim or
trimebutene?
No, I don't have any experience with that, I'm afraid.
So then we have another question. Could you please give us a dose range for paracetamol?
So the dose range for paracetamol is massive, and I tend to use between 10 and 30 milligrams per kilo. However, the published dose range goes up to 300 to 500 milligrams per kilo, which means I would give a 2 kilo rabbit the same dose I would take. So I use a very, very low dose, and we're getting good clinical improvement with it.
Thank you. Then another question from Laura. Can you comment on megacolon versus cecal impaction in rabbits?
So I wonder whether, certainly with megacolon and cecal impaction, whether we have some of the similar sort of causation. And I think we're not very sure necessarily 100% what that is. But in terms of the cecal impaction, I wonder whether the initial cause is a similar neuropathy. But I think it's very difficult because what you really need to do is to biopsy the ganglia and have a really good look. And quite often that can be very difficult. I've managed to relatively successfully manage megacolon. But as I said, I think management of cecal impaction is really, really hard. I don't know if, Charlie, you have any different experience with that.
Well, no, actually, I have this. Was going to say the same comment than you. So yeah, I'm just following you on your comments.
Okay. I was hoping for a good top tip there.
No, unfortunately. Then we have a question concerning the dose of ranitidine you are using.
Right. So in terms of ranitidine, you see, this is the trouble when you do it in mils per kilo. So I've got to say, I'm going to have to tell you in mils per kilo. We have an oral formulation that is standard throughout Europe, and I use 0.3 mils per kilo orally or 0.1 mils per kilo of the injectable. But in milligrams per kilogram, I don't have that in my head, I'm afraid.
And then finally, we have one last question from Francis. What is the dose of hyaluronidase you're adding to the sub-Q fluids?
So hyaluronidase comes in vials, so the single dose vials, and you reconstitute it. And I use 1 vial per litre of fluid, and I'm quite comfortable using it with just saline, or I'm quite comfortable using it with lactated ringers or Hartmann's. But one vial per litre, yeah.
And so one last question that will be and after that. How useful are, in your opinion, fecal cultures and antibiotic sensitivity in your experience? So
for issues with gut stasis, unless... diarrhea is a little bit of a different thing, but in my experience, fecal cultures are not very useful in cases of gut stasis. If we have diarrhea and I'm looking for potentially something like salmonella, then yeah, that's a very different thing. But in most of these cases, I think antibiotics have potentially caused the problem or are not going to fix the problem. And generally, in my experience, most of these issues are not bacterial in origin. And I think in terms of things like looking for Clostridia, I think we'd be better off trying to look for endotoxin rather than culture it, truthfully. But often, you know, these animals are unwell or dead by the time we get those results.
All right, and I'm just going to say there was someone who didn't heard your dosage of ranitidine. So in milligram per kilogram, it's usually around 2 to 5 milligram per kilogram. You can give it. So just to repeat for the person who didn't hear and who was asking in milligram per kilogram. Well, thank you again so much, Molly. That was really a very great webinar. I think everyone here really enjoyed it. And so thank you again, Molly, and we'll see each other next time around July for the next webinar. You will receive some information through the mailing list of AMV. So have a very good evening or day or afternoon, everyone, and see you soon for the next webinar. And thank you again, Molly.
Okay, thank you, Charlie. Good night.
Goodbye, everyone.